And the computer lady told me it is recording. So welcome to the March Open Forum. My name is Dr. Karin Duncan. I am one of the 4 physicians here at Coeur d'Alene Healing Arts, and my focus is on neurologic conditions with a even smaller focus in Parkinson's disease and people with Parkinson's and their caregivers. I've been at the clinic here for almost 3 years and love the work that I do in the community and being present with you all. And the open forums are just another way that we get to connect with our community and offer information and guidance that might not be utilized elsewhere. These open forums are recorded. So we are recording now, and they'll be available on our website at your convenience. And that website, like I mentioned before, is cdahealingarts.com. So today's topic that I chose and kind of alluded to before is Parkinson's disease part 1. I had started talking and then had to press record. So part 1 is because if you've ever heard me lecture about Parkinson's disease before, I'm usually allotted an hour time frame, and I go at super speed and try to cram as much in as humanly possible to that lecture to make sure that the listeners have as much information as possible. So what I really wanted to do with this series is slow it down a little bit and say, hey, what is it? How can I recognize it? When should I get tested for it? Why is it there to begin with? And what are some of the initial steps that we take? And then move through this slowly so that you all have chances to ask questions, or that you can watch this video later, or somebody that you love could watch that later and then come up with questions, and you can always send those to me, or you could ask your neurologist. So, classic definition of Parkinson's disease. The very first thing that I tell all of my patients who come in who have Parkinson's disease is that it's an inadequate definition of the diagnosis. Parkinson's disease is actually idiopathic Parkinson's syndrome. And why that's important to know is because Parkinsonism is this broad umbrella term for people with a movement disorder that looks like an alpha-synucleinopathy, which is the pathology of alpha-synuclein, which is a protein in our body. Welcome, Ken. I'm just going to have you mute. So it is a type of alpha-synucleinopathy. It is a type of Parkinsonism. There are many types of Parkinsonism that exist out there. And one of the first questions that I ask is, how do we know it's Parkinson's disease? With the idiopathic part there, it really means we don't know why. We haven't yet been able to find the root cause of Parkinson's disease, which in my opinion is why we haven't been able to find the cure yet. It is a disorder of movement, or a movement disorder. That's why we see a movement disorder specialist as neurologists. If you or a loved one has Parkinson's disease and you're seeing a neurologist, I do always recommend that we get a specialized movement disorder specialist on the team for anybody with Parkinson's disease. Their focus and specialty and expertise in the field is really necessary. So the motor symptoms of Parkinson's disease are typically when it's diagnosed, and that's a constellation of symptoms. Many people will say, hey, all I did is walk down the hall and my doc told me I had Parkinson's disease, or all I did is sign my name and they said I have Parkinson's disease. That's because, one, most of these doctors are highly trained to see all of the symptoms and the way that our body moves and put that together to make a diagnosis. But if you're curious of what those symptoms are that they're looking for, it's slowness, rigidity, a resting tremor, and unstable posture. Those are really what we call the 4 hallmark symptoms of the motor diagnosis of Parkinson's disease. You don't have to have all of the symptoms to qualify for the diagnosis or to have the disease process overway. We're going to talk a lot about the etiology, or why Parkinson's disease hypothetically is there. Like I said, we don't know for sure what the root cause is, but we're going to talk a lot about what they could potentially be. But really what I want to say is it's a combination overall of genetic and environmental factors. Predisposing genes, we know that family members are higher likelihood to develop Parkinson's disease. And we do know that there are some known environmental factors like pesticides that make it a higher risk to develop Parkinson's disease as well. So what we want to do to make the diagnosis earlier, which in my opinion would make us more successful at treating it, is recognize some of the other symptoms that might predate that motor symptom. By the time people get diagnosed with Parkinson's disease, based on the 4 physical symptoms that I just mentioned before. We have data that shows we have 80% depletion of the dopaminergic neurons in the basal ganglia of our brain. 80%. So by the time we're making the diagnosis, we're 80% in the hole of disease progression. And again, this is why I think that we're starting from behind, and that way finding a cure during the disease process has become so difficult. So what are some of the classic non-motor symptoms that often will predate the motor symptoms we talked about, the slowness and the rigidity? Well, there are 3 that I have started treating in my practice as seriously of a constellation as we see with people with heart disease. You can ask anybody on the street for the most part, hey, what are 3 risk factors for cardiovascular disease? What does your doctor ask you every time you go in to see, are you smoking? Are you overweight? Are you sedentary? Do you have a family history of heart disease? We screen for these in every run-of-the-mill primary care visit, every Medicare visit. I mean, people are asked these questions over and over and over again to screen them for cardiovascular disease. My question is, if we have the data to show that constipation, anosmia, or a lack or diminished sense of smell, and REM sleep disorder, some sort of sleep disorder, are risk factors for developing Parkinson's disease, in the sense that it's not necessarily a risk factor, that these could actually be symptoms of Parkinson's disease, non-motor symptoms that are predating the diagnosis. So that the disease is actually present before the motor symptoms show up. This is a later manifestation. And then if we were to start treatment in that situation, let's say somebody's 40 years old and has that constellation of symptoms, if we were to treat in the preventive way that we know that we'll see more in part 2, could we actually then cure Parkinson's disease, slow the progression, or make it so that that person actually never gets a diagnosis, even though Parkinson's disease exists in their body? So by the definition, we have a Parkinson's disease right now. Essentially catching it earlier on by the presence of known non-motor symptoms would lead me to think that they may never progress to the point to get the motor symptoms in general. So I hope that's landing okay. I'm going to pause here for a second and see if there's any questions on that concept. And again, you can unmute yourself and ask freely. There's a little hand raising button on Zoom, or you can use the chat box. Let me open my chat box open so I can see. Okay, so we're all hanging in there then. So what's happening in the body? What is the actual process of dopaminergic neuron death? Oh, go ahead, Ken. That's a great question. Does it have to be all 3? No, you don't have to have all 3 to say, hey, if you're constipated, then you're going to get Parkinson's disease, or this could be a non-motor symptom. Now, what I will say with full bias is that a practitioner who sees Parkinson's disease day in and day out, anybody who walks in my clinic and says they have constipation, I'm not thinking Parkinson's disease, but really constipation is an inflammatory response of your GI system and can lead to many chronic inflammatory conditions. And the very simplest way that I say that to people, so it really sits true, is that constipation is something that needs to be treated and not just palliated, is that if you are not eliminating the toxic waste from your body, which is what feces is, and you're not eliminating it, it's staying in your body. And it's truly as simple as that. If we are not eliminating, then it is staying in, and it is toxic sludge. And so, to be really honest, if you have constipation, a long-term constipation, I am thinking maybe not Parkinson's disease, but hey, we need to treat that because it can lead to other things. If you have 2 of the 3 and you come into my office, or somebody else who's really practiced at treating Parkinson's disease, I can guarantee you we're thinking along those lines. Hey, these are 2 of the non-motor symptoms that are really common. Do you have a history of it in your family? Do you have any neurologic symptoms in your family? So we're going to start asking those questions. If your doctor isn't asking you questions like that, when you're having those, then you can always bring it up. Or if a loved one say, hey, like maybe we talk about this. My dad had Parkinson's disease and I'm feeling this at, between the ages of, 40, 60, whatever the case may be. And I have concerns about developing that, then I don't see any harm in taking a preventive route to it. And again, we're going to talk a lot more about treatment in part 2. Hopefully that answers your question, Ken. So I was going to move on a little bit to, so what's actually happening in the body. So I'm going to kind of give the book answer, and then I'm going to tell you something that I learned when I was training under Lori Mishley, is that the book answer is that there's an aggregation of misfolded protein called alpha-synuclein in the basal ganglia of the brain, which is the part of the brain that's responsible for coordinating movements. And this misfolded protein, alpha-synuclein, it's a big protein. And when it gets misfolded, it will aggregate. And then the aggregation of that will actually kill the dopaminergic neurons. And then there's 2 aspects to that, like I said, that I learned later on in my training that I thought were really fascinating that I talked to my patients about. So that's kind of the book answer. Here's what's happening. And then when you look at the clinical trials and the pharmaceuticals that are being researched and the different medications, so many of them are really trying to attack alpha-synuclein. How can we kill alpha-synuclein? How can we get rid of alpha-synuclein? This is the protein that's causing the disease. And while that can be really beneficial, and I'm not saying anything about that, my question, and a lot of the questions that come in an integrative field of medicine, is why is it there in the first place? Where is it coming from? And what I learned later is that alpha-synuclein is actually a protein that is made and created intentionally by our intestinal system when it's inflamed. So when our intestines are inflamed due to constipation, food poisoning, whatever the case may be, there's an inflammatory bowel disease, vagal nerve dysfunction, which we'll talk about as well. When they are inflamed, they will release this SOS call of alpha-synuclein that is there to communicate with the immune system and let the body know it's in distress. So this is an intentional product that our body makes that then is aggregating in the brain. How does it get to the brain? From the gut. The current theory that is gaining a lot of traction, even in the conventional world, that has been published over and over and over again, is that vagal nerve highway. We have the vagus nerve, which is cranial nerve 10, that comes from our brain and runs all the way through our body, all the way down to our rectum. It's the longest nerve in the body. In Latin, it means the wandering nerve. And it is responsible for the parasympathetic output of the vagal nerve, is responsible for that parasympathetic nervous system tone, that rest, digest, restore, and heal. And it connects the GI system and its enteric nervous system, the nervous system that wraps around our GI system, to the brain directly. And the interesting thing about that is where it synapses in the brain anatomically is right near the basal ganglia. And so, like I said, the theory that we have is as we produce this alpha-synuclein from the GI system when it's inflamed, that it can travel to the brain along this vagal nerve highway and then accumulate there because, one, it's not supposed to be there. So it does become misfolded along the way, and then it will cause destruction there. The second part that I thought was fascinating that I learned later on, of course, and it seems like common sense, but when you really start to think about it, is that when we get diagnosed with Parkinson's disease based on motor symptom presentation, I'm going to keep saying that because I think we're late to the game. We have 80% depletion of our dopaminergic neurons. We also have a 60 to 70% depletion of glutathione. Glutathione is the primary antioxidant of our central nervous system. So if you think of oxidative stress as being the garbage and the glutathione as being the garbage truck that takes it away, as we are killing off dopaminergic neurons and they are releasing their parts, right? As cells die, all cells die, they release their insides, and that causes oxidative stress on neighboring cells and neurons. That's why we have detoxification systems. That's why we eliminate. But as that happens, it doesn't always have to be the alpha-synuclein that's causing the destruction. The death of the dopaminergic neuron could actually be contributing to the death of the neighboring dopaminergic neuron, if you're understanding this correctly. And this cascade or domino effect is even further perpetuated because the garbage it's created in its death isn't being taken away because we're also depleting glutathione. So again, I'm going to talk a lot more in depth about glutathione in part 2, but I want to bring more clarity to the term neurodegenerative and say, maybe the cure for Parkinson's disease isn't right here, but is there a stop to it or stagnation to it close if we can recognize what's contributing to the death of dopaminergic neurons and then help relieve some of the burden of that pathology. So again, I'm going to take a pause here for a minute. I know I'm trying to, translate into layman's terms and I get on a roll and sometimes it doesn't always come out. So if there's any questions or clarifications I can offer up until this point, please don't hesitate to speak up. So the other protein that I wanted to mention is because it's a really commonly one used when we talk about the pathology of Parkinson's disease is Lewy body. Lewy bodies are basically a compilation of alpha-synuclein and something called ubiquitin. They're two proteins that are associated with the disease progression. Lewy bodies aren't always necessarily bad. A lot of people in their aging time in their life, about 30%, even if they don't have neurologic symptoms, will have positivity for Lewy bodies, on autopsy. So what we're trying to say is the presence of Lewy bodies doesn't necessarily mean disease. And Lewy bodies often are actually used as a protective response in the brain to remove the alpha-synuclein. So really what is happening is we're having these Lewy bodies or the alpha-synuclein being made by the intestinal cells due to inflammation. They aggregate in the brain. The Lewy bodies are created to help clear those out. And then we get these aggregations that then can perpetuate disease. Now, if it's balanced and we don't have disease progression, then those Lewy bodies are probably helping to eliminate the alpha-synuclein. So really it's something has gone wrong in the system that's already in place in the body. And we have not been able to fix that yet. Now, some of the other theories out there about why Parkinson's disease exists is there's an autoimmune theory about there's an immune system dysfunction where the immune system turns on self, therefore causing inflammation and leading to a Parkinson's disease. And that is kind of ubiquitous in the neurodegenerative world. Is there something there that's affecting it? There's more metabolic theories, just in addition to intestinal inflammation, but the blood sugar dysregulation, there's hormonal dysfunction. There's, of course, the environmental aspect to it, toxic exposure and toxins. There's the genetic component. And I'm stressed. Sorry, there was one other big one that I was thinking of and it just ran away from my brain. So these theories that lead into why Parkinson's disease exists is really where I feel the research needs to be focusing on is in what is happening for this particular person. And so that was the thought I was going to have, is that there is this quote out there in the Michael J. Fox Foundation is, once you've met one person with Parkinson's, you've met one person with Parkinson's. And I can attest to this in my practice. I see hundreds of patients with Parkinson's disease and none of them respond exactly the same way. There's not this algorithm to how to treat the disease, because one, it's showing up differently for everybody. So we take these 4 motor symptoms and say, you have Parkinson's disease. It doesn't necessarily mean that you are exactly the same as Joe over here who has Parkinson's disease. And 2, the reason that it exists in your body is different than the reason it exists for other people. The one true thing that I have seen so frequent in my practice is that we have these constellation of non-motor symptoms that predate motor symptom and diagnosis by sometimes 10 to 20 years. And people will say, but it was fine. I was living with it. Nothing was really different. I was, taking my fiber and whatever else the case may be. And then I got a divorce. Or then I lost my loved one, or then I got diagnosed with cancer and underwent treatment. And so the presence of trauma in the narrative of people with Parkinson's disease, as that's when it tipped the scale into moving into motor manifestation and then diagnosis, is really astounding. And it's so common to hear that I had these non-motor symptoms, I was managing fine, I was in good health, and then this happened and I could tell everything took a turn for the worse. So it's really fascinating to kind of explore that with my patients as well, because that does lead us into this more of a timeline of when did we tip the scale into not being able to clean up that mess and continue the death of the dopaminergic neurons. So that's a little bit of the how, the why, what is Parkinson's disease? How does it show up? Anxiety is another huge non-motor component of Parkinson's disease. It's not in the main 3 non-motor constellation. But the reason that I put so much weight in anxiety for people with Parkinson's, or even people that I might suspect might have a non-motor presentation of Parkinson's disease, is that it also represents something that we call vagal nerve dysfunction or dysautonomia. And so when we have anxiety, more often than not, we are living the sympathetic nervous system tone, which is the fight or flight tone. And really the fight or flight is a shortened version of fight, flight, freeze, fawn. Fight, flight, freeze, fawn. And then there's fornicate and food. There's a lot of F's that, if you talk to a clinical psychologist, say there's a lot of F's in the sympathetic nervous system tone, but we really think about that fight or flight mode. And when somebody is living in a constant state of anxiety, they're in that sympathetic nervous system tone of fight or flight. And when we're in that nervous system tone, we are not in the parasympathetic nervous system tone, which is rest, digest, restore, and heal. And that can lead to some of the other non-motor symptoms like constipation, right? Slow gastric motility, because we're not making digestive enzymes. We're not moving things along in our digestion because we're fighting or flighting. We're running from a bear. And so when somebody presents with anxiety with or without the diagnosis of Parkinson's disease, the importance of helping them balance their nervous system tone to make sure that we're giving our body's physiology all that it needs to function is really essential in my opinion. So now we get to the point, once you've been diagnosed, you've seen your neurologist, you walk down the hall, you have a head tilt, a lack of an arm swing, you have cogwheel rigidity, you have a resting tremor, constipation, anxiety, whatever your constellation of symptoms are, you have this diagnosis. And then what comes next? Typically, the majority of the time, for most of the neurologists that I see and myself, if I'm making the diagnosis of Parkinson's disease, is a prescription for a medication. I'm going to pause here for a moment because I just did get a question. Can meditation assist in preventing the tipping of scales towards Parkinson's disease? I'm going to say absolutely, probably it depends. There is always going to be a benefit of meditation or mindfulness-based practice for most people. I caveat that with people who have adverse childhood events and who have severe PTSD or trauma in their childhood. Sometimes meditation can actually be triggering for those folks, and they need to kind of ease into that type of practice. So I'm going to back meditation up a little bit with mindfulness-based practices and intentional balancing of the nervous system and stimulating that vagal nerve can absolutely be preventive in tipping the scales towards any chronic inflammatory condition, including Parkinson's disease. Not only can it be extremely preventive, it can be extremely therapeutic in the treatment of the disease. So great question. And then just kind of coming back to next steps. Typically what I will see in the order of events here, the chronology of it, you get the diagnosis, you need to get a prescription. The majority of the time, that prescription is for carbidopa-levodopa. And carbidopa-levodopa is a synthetic blend of dopamine. The L-dopa is L-dopamine. And then the carbidopa is I call it the carrier, the shuttle bus for dopamine. We have dopaminergic receptors all throughout our body. So when we pair that levodopa with carbidopa, we're actually saying, we're going to hold on to you until we get to the blood-brain barrier. And then we're going to make sure that it's most highly concentrated there and kind of deliver that medicine to the brain instead of everywhere throughout the body. So that's typically the first prescription that neurologists and myself will make. Why do I back up that prescription right off the bat? Let me start off by asking, why wouldn't somebody? A lot of people will say, once you've been prescribed and started on carbidopa-levodopa, you only have 10 good years until it wears off in its efficacy. I counter that with, by the time you get diagnosed with Parkinson's disease due to motor symptoms, we are 80% deplete in levodopa. It is very challenging to ask your body to heal from that deficit by doing anything, lifestyle, diet, exercise, mindfulness, meditation, and create more dopamine from that kind of deficit. And one of the other major non-motor symptoms of Parkinson's disease is an emotional state that we call apathy. And I like to say the kind of not giving a shit phase. I know I need to exercise for my Parkinson's, but I don't want to. I know I should go out to eat tonight with my friends, but I don't want to. I should probably get on this lecture Dr. Karen's putting on, but I don't really want to. Lack of motivation or care to do the things, even when we know they're going to give us benefit. It's one of the deepest conversations I actually have with caregivers of people with Parkinson's that are saying, I am burned out from cheerleading, is that this is actually a symptom of the disease, that they don't care. So it's really hard to convince somebody to be in that state. So when we are that deplete in dopamine, then I see the most advantage of taking that medicine and trying to refill that bucket. Just how empty it is, we don't know by the time of diagnosis, but it is worthwhile, in my opinion, to take the most natural thing that we can give somebody with a dopamine deficiency, dopamine. I liken it to, if we have somebody with an insulin deficiency, like somebody with type 1 diabetes, we prescribe them insulin. We don't say, hey, body, make more, do better. We can do that in conjunction with, to try to improve insulin sensitivity and help the health of the pancreas and blood sugar regulation. But in essence, we say, you are depleted of this, you can't make any more, we need to give it to you. So, and the second part of that is, if it's going to give you 10 good years, or let's just say on average 10 good years of treatment, one, that buys us 10 good years to do our due diligence and find more, trials and treatments and remedies to help with Parkinson's disease. And two, that gives you 10 good years of life, quality years of life, where you're managing your Parkinson's symptoms. Now, to be very clear, carbidopa-levodopa, or the brand name Sinemet or Rytary, is not disease modifying, which means that medication does not slow down the progression of the disease. It is merely there to give your body the dopamine on the back end that your brain can't make on its own. So it's there to palliate symptoms. So the need for more of it as you continue in the disease is going to happen, because it's not slowing the progression of disease. On the market right now, there is only one disease-modifying medicine, and that is rasagiline or Azilect. And so that is another medication worth considering when you're talking to your neurologist right off the bat, saying, I know that there's some small evidence that this can slow disease progression. Only a handful of patients that I have seen have an adverse response to it. It's always a possibility. But I talk to my patients every time, is I'm always saying it's worth the try to get that slowing of disease progression as soon as possible. Some physicians will start right off with something like a pramipexole, which blocks the uptake of dopamine from the bloodstream. So similar to like an SSRI with depression, this is going to keep dopamine in the bloodstream a little bit longer. Some of these medications and agonists are not terrible. They are helpful medications, but the side effect profile, in my opinion, tend to be a little bit bigger. One of them being personality changes and compulsivity. So anybody who's on an agonist, we check in regularly. Are you gambling? Are you spending money? Are you, as my mentor say, how many times do you peed in the parking lot? Are you acting compulsively? Or having behavior changes? And this is often where a significant other or family member comes largely into play in the care to see if this is something that they are seeing change. Another really good question, are there ways of testing for dopamine levels? Nothing that's been approved yet to be accurate. Now, there is an imaging test that they will run if they are questioning that diagnosis of Parkinson's disease. If it's still under the umbrella of Parkinsonism, they will run what's called a DAT scan. And that's a scan of the brain that looks for the concentration of dopaminergic neurons in the brain. The sensitivity and specificity, I don't know off the top of my head, but I do know that if it is positive, if it shows a loss of dopaminergic neurons, then we are more likely to suspect Parkinson's disease. If it is negative, that doesn't necessarily mean it's not there. So it's one of those things that we can help rule out other conditions or rule Parkinson's disease in. Now, in my practice, I do use what's called the Dutch test, which is a urinary metabolite test, where we can see what the metabolites are that lead up to the production of dopamine in the body and see if those are low. So typically, I will make a clinical diagnosis of Parkinson's disease, but if I am questioning it, hey, this looks like it, but I wanted, I have some other concerns or maybe other thoughts, then we can order a DAT scan, or I will run this urine test to say, hey, are you low in some of these metabolites that would lead you to be low in a dopamine in your system that then could confirm the diagnosis? but nothing, which I think the question is probably leading to, nothing definitive or diagnostic out there to say what are your dopamine levels at this point in time. So going back to some treatments. So the levodopa we talked about, rasagiline we talked about dopamine agonists. There's a lot of different flavors of medication. And again, in my opinion, the safest and most simplest way to start treatment is to get on something as quickly as possible to replete that dopamine in your body. And what I see in my practice a lot is if we can get you on a therapeutic dose that helps lower the symptom burden in the body, improve quality of life, help keep you motivated for the exercise, and then look at this entire other picture of your health and start healing things like thyroid and nutrient deficiency, anxiety and depression, GI issues to be the biggest one, then actually the body's need for exogenous dopamine can actually go down and maintain that quality of life. So many people will question me on that and say, how is it possible that I need less dopamine as my disease progresses? And that's where we start talking about healing and getting glutathione in and much more things that we'll talk about in the next segment. In part 2 is the treatment and why it works and how it works and what to be looking for. So again, I'm going to pause because I did get on a kind of a rant there for almost 10 minutes to see if anybody has any questions of where we are right now. Okay, everybody's feeling okay? All right, so now we have the diagnosis. Now we have some medicines on board, and many times, just because of the paradigm of the system right now, it's, hey, you have Parkinson's disease, here's your medication, I'll see you in 6 months. And then that's a lot of times when I'll get patients come into my office and say, I just got this diagnosis, here's my medicine. What do I do now? How do I use it? I don't feel good when I take it. I'm getting nauseous. I have some orthostasis, which is that dizziness when we go from sitting to standing, which actually can be a symptom of Parkinson's disease. And it also can be a side effect of the medication. So what do we do at that point in time? This is the point where I love to come in and join the team and be invited on the team and say, here are all the things that we know in our integrative research that can help slow the progression of the disease. And whether that's through dietary intervention, whether it's through exercise, whether it's through nutritional supplementation, whether it's through further testing of your physiology and biochemistry to ensure that other pieces and processes and functionality are intact, we start there. One of the main places that I start, as I've alluded to before, is testing your GI system. It's the theory that has the most traction. The highest percentage of non-motor symptoms for people with Parkinson's is constipation or slow gastric motility. So let's dive in. Let's start there, because instead of prescribing a bunch of oral medication that your body may not be able to absorb or metabolize or assimilate, I want to see what level of GI inflammation is happening there. Is there an imbalance in your microbiome? Is there another concomitant condition called SIBO, small intestinal bacterial overgrowth, that often will manifest with chronic constipation, and that perpetuates this intestinal inflammation pathway? So really the first place I start is, okay, we're giving your body the dopamine that it needs with this diagnosis. Now let's figure out where it's coming from. Is it coming from your gut? Is it coming from somewhere else? And let's start testing and treating those places so we can slow down that root, that origin. Can we stop the alpha-synuclein being produced in your intestinal walls because they're not inflamed anymore? And oh, by the way, we're having bowel movements every day, so we're getting rid of this toxic burden in our system. And now we can start cleaning things out. So the next steps that are recommended here in this office are, let's figure out what's going on in your physiology so we can get to the bottom of it and get to healing yourself. A metaphor that I often use, I work closely with my mentor, Lori Mishley, and her life mission is to cure Parkinson's disease. And I will do everything to support her in that. And I believe strongly she's going to be a huge part of the cure when it does come. And also, because of my belief system and philosophy, a cure to me is the absence of symptoms, is leading the quality of life that you desire with a disease or a diagnosis without suffering. And so when I look at people with Parkinson's, I'll often say, I feel like you're lugging around this suitcase that is your diagnosis. Here's my Parkinson's disease, and everything that I do and everywhere that I go, I'm having to be cognizant of this or aware of this. So 24/7, I'm always thinking about Parkinson's disease. But what if some of those symptoms of Parkinson's disease were actually due to some other imbalance in your physiology or your health? Then that would be really important to understand, treat, and address, so we can take one of these symptoms out of the Parkinson's bucket, put it over here, and then get rid of it. And now that Parkinson's bucket shrinks a little bit. And we keep doing that, and we keep optimizing your physiology to the point where Parkinson's disease is still there. And maybe we're still taking some medications for it, but the suffering from the symptoms of it that may have overlapped with other imbalances or dysfunction in the body have improved or resolved. So in essence, I'm not going to say it's a cure, but it's about as close as I think we can get with the people who have it, the disease right now, until we really figure out what that idiopathic part is and start treating it earlier, start diagnosing it and treating it at an earlier stage in the disease progression. Are there any questions on that concept or theory there? Okay. Well, just because we do have about 6 minutes left here, and we really kind of went through a lot of the concepts here in phase one. Oh, we do have a question. What % of patients have associated psychologic problems? That's a really good question. Mental health, as it pertains to Parkinson's disease specifically, I'm going to say 100%. In my practice, I won't speak for worldwide, but in my practice and my work in the Parkinson's disease summer school in Seattle, I have yet to meet somebody who doesn't have some sort of anxiety or depression, or some sort of mental health aspect to the diagnosis. I have a lot of theories behind why that might be. And that's not to say they're not extremely resilient, strong humans. There's a whole attachment of grief to the diagnosis. And I think depending on how people are diagnosed and what they know of Parkinson's disease will directly affect their psychology going into the disease course in themselves. But as far as like non-motor symptoms of Parkinson's disease, like anxiety, I'm going to say that's probably over 75% of my patient population. If, I don't know exactly, but I'm going to make my best guess here is over 75% of people with Parkinson's often will tell me, to be honest, that the non-motor symptoms like anxiety, apathy, constipation, urinary difficulties, low libido, are more bothersome to them than the physical symptoms. As one patient so eloquently told me, I'm old, I'm supposed to be slow, but I'm not supposed to feel like this. And so I'm not saying that applies to everybody, but I do feel like it is very common. And then you just corrected and said you meant concomitant physical problems. Can you unmute and just ask me your question? I think I'm having a hard time understanding it.
Dr. Karin, I was just wondering, you said there's these more direct indicators, but then, you said your approach is to take a broader look and see if there's other things going on that may be happening at the same time that the Parkinson indicators are there. And I was wondering what percentage of the time you find your patients do have, ancillary problems that you detect in addition to what the main focus is. That's what I was.
I got it. No, great question. So I think that, yeah, and I think so physiologic, like, are there other upsets or imbalances in the physiology that could be contributing to or misplaced in the Parkinson's
Right. You
bucket?
talked to that. I was just wondering, based on your experience, is it 50% of the time I find there's problems out there.
Yeah. No,
that kind of
that's a
thing.
great question. I would say it's much higher than that. I would say, again, I kind of go with that 75%. It feels safe. It's definitely more than half. My gut instinct is to honestly be like closer to 90. But I want to be a little safe in my my overestimation. And here's the other thing too. I go looking for it, right? I'm doing the testing, I'm doing the investigation. I'm open to saying, hey, is this a thyroid issue? Is this a cardiovascular issue? Is this a metabolic imbalance? Where I think some people who don't ever see a naturopath or somebody who's going to do more investigating won't ever know if they have these concomitant conditions. But we do go looking for, do you have GI distress or SIBO or something there? And if you test positive and we treat, do your symptoms improve? And the answer is ubiquitously yes. We are seeing that happen. I mean, I have patients who we've cut back their dopamine doses by 30 to 50%, and they've had the diagnosis for over 10 years. So when we find something, this could be contributing. I think you put this in the wrong bucket. This isn't a Parkinson's symptom. This is a you symptom. This is a something else symptom. Then we start to see it's not that we're curing Parkinson's, is that we're healing the body. And I think that's really where we need to come back to. Does that answer your question? Yep. Did that answer your question, Ken?
Can you hear me?
Now I can. Yep.
Okay. Yeah, thanks for giving me that indication. 80 to 90% or whatever do have other things they're dealing with in addition to the situation. But then that raises the question, how do you they're taking certain drugs for Parkinson's, which have side effects, and does that complicate, your diagnosis of the other things they're dealing with?
I mean, sometimes it can. Yeah, these are great questions. Sometimes it can. We have to take that into account. And that is something that, is the onus of the physician doing it. But oftentimes if they are on, your run of the mill carbidopa, levodopa, then there isn't a whole, long side effect profile that would then kind of blur the lines of, is this that, or is this another diagnosis? So we are looking for, not just like symptoms that we can misplace out of the Parkinson's bucket. I'm looking for diagnoses. I'm looking for actual dysfunction in the body that maybe got ignored or neglected or never looked into because it lined up with a symptom of Parkinson's disease. My mentor had a slide in one of her initial presentations, Lori Mishley, about here are the list of symptoms, and I have it somewhere. If anybody's curious, here's the list of symptoms that patient X reports, and this giant list of symptoms. And so for their nervous system function, they went to a psychiatrist, and for their cardiovascular symptoms, they saw a cardiologist, and for their neuro symptoms. So you get where I'm going. The GI symptoms, they went to a gastroenterologist. And so they went to, 5 or 6 different specialists for these symptoms that they had. And each specialist then prescribed a medication to palliate that symptom. And then each medication had a side effect that could have interacted with another medication that then created another symptom picture, which then would require you to go to another specialist. And the very next slide, she said, what is the diagnosis? And we sat there and we said, you just told us what the diagnoses were, right? It's heart palpitations and arrhythmia and, anxiety and da-da-da-da-da-da. And the final slide was B1 deficiency. So in that moment, it was just so, in a clinical practice, say it can always be this and it can always be this and something else. And even though the shoe fits, Cinderella, it doesn't necessarily mean that's the only size 7, right? That there could be so many other things that fit into the symptom picture that I'm not saying it's not Parkinson's disease, but if a portion of that was contributed to by the body's ability to hold multiple different conditions, then I want to zoom out to 20,000 feet and say, are we looking at other things that could contribute to all of this? So hopefully that makes a little more sense for that question.
Thank you.
Yeah, of course. So with that, we are kind of nearing the end of the lecture here. I lecture every 3 months. So this is March, April, May, June, I believe is my next lecture. And that's Parkinson's disease part 2, where we really dive into treatment and treatment options and further testing and what that looks like and responses and the progression and, everything else that kind of comes next. But like I said, being able to slow down from my normal hour lectures where I try to cover it all at once, I wanted to take the time to say, what is this disease? How is it diagnosed? How are we initially approaching it? And what can you expect? And it's different for everybody. And it's different with every neurologist, and it's different with every naturopathic doctor. But having a little bit more information about what this looks like and the fact that there are options is really my hope, is that I empower people to advocate for themselves and say, hey, doc, I heard about X, Y, and Z. And oh, hey, by the way, I know you're saying I can wait a few years before I go on levodopa and I can do my exercise and I can do my diet. Would it be okay if I started a low dose right now? Or I'd like to explore the option a little bit more, and just having a little bit of our knowledge base to say, what are my options? What else is happening in my body before I go, press the alarm button, say I have Parkinson's disease, I'm doomed. I had one patient tell me that her movement disorder specialist, which broke my heart, said, you have Parkinson's disease. You're walking, you walk slow, you get a cane, you get a wheelchair, and you die. And I just sat and cried with her, because it's not to say that that's not the truth for some people, but it's just an awful way to hear a diagnosis for yourself without a glimmer of hope or options or what's even happening in your body. So, if I had one thing to say about my practice, is that I want to offer options. I want to offer, hey, there's other things out there that can help and slow down the progression and help your symptoms and enhance your quality of life. And oh, by the way, this might not all be, let's blame it on the Parkinson's disease. Let's look, let's see what else is happening in your body, because you're a whole individual human and every aspect of you communicates with each other. So we've got about 1 more minute. If anybody has questions, feel free to throw them in the chat box or unmute yourself. The email to our clinic is info@cdahealingarts.com. If you have a question that pops up later, you can always write that to that email address and just say, I want to send this to Karin about her lecture today with Parkinson's disease. You can always reach out and ask questions. We do offer free 15-minute consults. So if you or a loved one thinks you're at risk for Parkinson's disease, has a diagnosis of Parkinson's disease, whatever the case may be, you can always call in and schedule a 15-minute chat with me to learn a little bit more about what that would look like here at our clinic. And like I said, I appreciate you showing up today. For those of you watching the recorded lecture later on, I appreciate you being here as well. And that also applies for the recorded version. So be well. We're almost to fast forward for spring. The sun is out. And I hope to see you all in a few months for part 2. Bye.